இந்த ஆடியோ எல்லாத்துலயுமே தான் பிரச்சனை. இதுக்கு இருக்கு ஓப்பன் ஆடியோன்றதுனால தான் இதுக்கும் கேட்க முடியும்.
அவள்தான் அதுல போட்டாலும் கேமரா எடுத்துட்டு போ அந்த ஆடியோ கீழே ஆடியோ நியூ பேர்ல அவங்க
இதுதான் நான் சைட்ல போட்டுருக்கேன்.
வந்து மாத்த எனக்கு
எனக்கும் தெரியும், அவங்க மாசம்னா எனக்கு தெரியாது, நான் மாட்ட மாட்டேன்.
சென்டர்ல போட்டா கேமரா ஆஃப் பண்ணி முன்னாடி
போட்டு போறேன் பேச்சு
In the check right back here.
Yes.
Yes, sir.
What did you say?
Some more very sharp. Very sharp. Very nice.
ನಾನು ಏರ್ಪೋರ್ಟ್ Yes. Oh.
Mine is a very brief. 2 minutes.
Hello.
Anthony Colombo.
Nice to meet you. Thank you for having me here. No, it's I saw the cat lab and so skills very high. Well, I knew them. Every time to see the game.
A very good afternoon to one and all present here. It is one of the happiest days for our Cardiac Care Center and University to conduct the third Dr. Thanikachalam Sir Endowment Oration of Cardiac Sciences. On behalf of the faculty, staff, and students of Cardiac Care Center, we cordially invite our special guests, dignitaries, faculty, staff, students, ladies and gentlemen. We are honored to have Vice Chancellor Dr. Ramachandra Ma'am, Professor Dr. Anthony Colombo, Professor Dr. S. Thanikachalam Sir, Professor Vice Chancellor Dr. Mahesh Vaikamudi, Dean of Medical Sciences, Dr. Balaji Singh sir, on the dais.
ரெக்கார்ட் போகலாம், ரெக்கார்ட் போட தம்பி. நம்பிக்கை பார்த்துக்கலாம். கிளம்புறவா? கிளம்புறவா?
Now we will begin the program with an invocation song followed by the college anthem. Next, we would like to invite our guest, Professor Anthony Colombo, sir, and respected Vice Chancellor ma'am to light the lamp. Thank you, sir. Thank you, ma'am. Welcome address by our Professor Dr. K.R. Muralidharan, sir, Head Department of Cardiology.
On the day of the day. It gives me immense pleasure standing on the third Endowment Oration of my 11th thing for Oration. This was started 4 years back. Due to the pandemic, COVID pandemic, we could not do for 1 year. So we have started this year third endowment. I take great pleasure for the endowment lecture to welcome our respected Vice Chancellor, Dr. Ramachandra Madam, to come here, grace the occasion, to be here, pillar be in. My next special thanks to Professor Anthony Colombo. The day we requested him during visit to India, could you please be with us in our center to do cases and to deliver the endowment lecture? Immediately accepted to do this, sir. Our sincere thanks on behalf of my department, my university, for accepting and being here with us. I can talk about my chief for a long time. For this reason, sir was reluctant to come. I said, no, you are like not only our chief, you are like our father. You have to be with us on the diet. Thank you for yielding to our request to be with us on the diet. My special welcome to my friend and the Pro VC, Dr. Makai Tokamudi and Professor K. Balaji for being with us in this afternoon. I don't want to take much of your time because the Oration is a lot of work by special events are there now. But I have to say one thing. The whole idea of started with the simple thing, we have to disseminate the knowledge. This is always wanted that. We have to disseminate the knowledge, be a guiding force. Like Vallo said, Tamil Tammakal Ariyulamai, Manasathu Manvirikkalam. What it means is the next generation should carry the task, go forward, go to higher targets. We would like to take the work sincerely, and here we have a world-renowned cardiologist, interventionist of great reputation for Antonio to guide us in this path. So it's a great pleasure for us. We thank you all, sir. With this viewer, I welcome the district faculty officer, and my special welcome to all the senior professors, members of the management, various faculty of the college, my dear friends, students, ladies and gentlemen. I welcome you all for great hour. Thank you.
Thank you, sir. I would like to call upon our beloved Vice Chancellor, Pro Vice Chancellor, and Dr. S.T. Thanikachalam, sir, to honor and bestow our esteemed professor to Professor Dr. Anthony Colombo. Thank you, sir. I would like to call upon Professor Jason Moody, sir, to facilitate our beloved Dr. S. Thanikachalam, sir. Yes, sir. I would like to call Dr. Venkateswamy sir to facilitate our beloved Vice Chancellor now. Thank you. I would like to call upon Professor Dr. Jason Murthy sir to address about the oration.
Respected Chancellor of the University, the Chief Guest who is to deliver from the Thanikachalam Endowment Oration in Cardiac Sciences, Professor Andrew Colombo, who is the Senior Consultant, Director, Cardiac Cath Lab, Columbus University, Milan. Vice Chancellor of the Ramachandra Institute of Higher Education Research, Professor Mark Rikaman, Vice Chancellor, Professor Mahesh Makamudi, Dean of the Medical College, Professor Balaji Singh, Registrar, Senior Consultants, colleagues, and friends. Head of the Department of Cardiology, Professor P.R. Muralidharan, Head of the Cardiac Surgeon, Professor Swami, Senior Consultants, and friends. It's indeed a great privilege for us in Cardiac Care Center of the Ramachandra Institute of Higher Education Research to invite for this prestigious third Professor Thanikachalam Endowment Oration by no less than one of the greatest interventional cardiologists of this era, Professor Anthony Colombo. Every cardiologist in India, whether clinical cardiology or interventional cardiology, they all revere him for his outstanding academic contribution in the field of cardiology. So we are all honored and happy to have you with us on this great occasion. Regarding Professor Thanikachalam sir's oration, it is superficial for me to introduce Professor S.T. sir to all of you. He is an astute clinician from the start, from his started his cardiology career in 1971. He had his initial training in cardiology in Christian Medical College with great doyens in cardiology like Professor George Cherian, Professor S. Krishnaswamy, Professor I.P. Sukumar, Stanley John, to mention few of them whom I know. These are the doyens in clinical cardiology who were the torchbearers of the successive generations of cardiologists. Today, what we teach and we talk because we are standing on their shoulders. After completing his training, he joined Madras Medical College in 1971 and was a part of the Academia of Madras Medical College. And later, he was in Kilmarnock Medical College. During his stay in Madras Medical College, he was one of the first persons who visualized the need for non-invasive cardiology ultrasound. Those are the days when echocardiography was just picking up, and many of our senior colleagues who were seen must have seen what is MOD, and you don't know. And many people lost the interest after seeing. But he is a person who visualized the potential of echocardiography. Today, MOD, 2D, 3D, and to mention everything is possible intracardiac echocardiography. All these things were visualized and painted by him, and hundreds of young cardiologists were nurtured by him, mentored by him, trained by him to be academicians, administrators, institute builders. Sir, because of your 50 years of outstanding contribution to the field of cardiac sciences, made it possible for successive generations to stand on your shoulder and reap the benefit of your training. In 1994, after his long stay in Tamil Nadu government service, we were privileged to have him in Ramachandra University, and some of us were privileged to travel with him in the last 28 years to see how he built his department brick by brick, layer by layer, both academically and clinically. Today is one of the foremost centers of this country, where a lot of clinical work goes on, and apart from research and academia is going on. Because of this constant endeavor, we could get DM cardiology as one of the first and earliest department, and over a period of time, we had a lot of trainees who are all over the country, and some of them are overseas. For his outstanding contribution, very little to be said is that he deserves much more. But to mention few of his recognitions, in 2009, he was awarded the prestigious Padma Shri Award by the President of India. In 2003, he was given Dr. B.P. Roy Award as the best teaching faculty. I'm not mentioning many, sir. He was given honorary doctorate of medicine by Tamil Nadu Dr. Indian University for his outstanding contribution for the world of cardiology. Lifetime Achievement Award from the same university, which was an alma mater for all of us. Sir, I only mentioned few and many more. With this, it's our privilege and pleasure to have this third oration by no other less than Professor Antonio Colombo, the outstanding academician, great interventional cardiologist, a mentor for hundreds and thousands of the people, not only Europe, across the globe. Welcome you, sir, to Amit Kai.
Thank you so much, sir. I would like to call upon Professor P. Manohar sir to give the introduction about the orator Dr. Anthony Columbus.
Good afternoon, everybody. After the round of introductions, the easiest job is to introduce Dr. Antonio Colombo. To put things in parlance, as an interventional cardiologist, I would introduce him as Virendra Sehwag plus Virat Kohli plus Sachin Tendulkar of cricket and interventional cardiology. Dr. Antonio Colombo is a trained cardiologist from Italy who went on to the US, developed, did his residency in the US, did his cardiology training in the US, was a consultant cardiologist, interventional cardiologist in the US. Then he went back to Italy, and whatever new techniques in cardiology today that we practice, whether it is with bifurcation stenting or whether it is with regulating balloons, all the technologies that we use today has some antecedent to Dr. Colombo's aphorisms. In fact, in cardiology, it is easier to quote Dr. Colombo than anybody else in the field of intervention. So it is a real privilege for us that somebody who has been recognized as the master of masters, somebody by the ACC and who has been accorded the, by the American College of Cardiology has been accredited as a master teacher. It is a privilege to have him here. And definitely people in the audience would understand why, as a cardiologist, we owe him so much of respect, and it is a great privilege for us to introduce the oration and introduce Dr. Antonio Colombo to this audience. Thank you very much.
Thank you so much, sir. I request our dignitaries to occupy the front.
Okay. This start. Okay. After all you heard, I really hope that I will be able to give you some meaningful message. First of all, thank you very much for having me here. Congratulations for all you are doing and what you have done. I've been in the cat lab for a couple of hours and I really understand how we do things, but then so many other people do even better than us. We're opening the area, but it's amazing to see how much progress young senior people have done. And this fact should really make people humble and understand that progress is one step after another step. I start with some historical slides, and then we go a little bit in what I consider the future. This is my personal opinion, but my first slide is about my first stent thrombosis, which made me think, and really every time you have a complication, the goal is to really think deeply about why you have the complication and not just impute the complication to bad luck. There is always, most of the time, an explanation. This is the stenosis in the proximal left anterior descending. This is the stenosis. At that time, 1990, was a clear indication for stenting. We placed the stent and was the palmar shots, 3 millimeter stent, inflated the 9 atmosphere, and this was a good result. This, I think, was my third stent implantation in my career. I did this procedure on a Friday. The patient stayed on heparin over the weekend, and on Monday morning, while we were having round, patient had chest pain while he was still on heparin infusion, and we were beginning anticoagulant. And thanks God, we were all present. We took the patient to the cath lab, and there was occlusion of the stent, thrombosis, despite heparin in therapeutical dosage. And this is the first consideration that stayed in my mind. We did balloon angioplasty, we opened the stent again, and thanks God, patient survived. He sustained a myocardial infarction, but he survived. At that time, there was no internet, there was no email. I wrote a letter to Dr. Schatz. Dr. Schatz is, along with Palmat, is called kind of the inventor of medicine. January 1990. I like you what I wrote. And this is the answer that Dr. Schatz sent it to me. Thank you very much for sending the film. I'm vitally interested in every complication so I can continue to learn from every case. If I have to point out a few things that may have contributed, the omission of percentage. We gave a dual antiplatelet therapy, but was aspirin and percent. Percent is a light antiplatelet agent. Inflow obstruction and underdilatation of the stent were factors. This could be a stroke of bad luck. But remember, 1990, Dr. Schatz already pointed out in a simple letter the key element to stent success. And this is not my contribution, it's Dr. Schatz's contribution. The omission of percent, which is dual antiplatelet therapy, inflow and outflow under dilatation, optimal stent expansion. So these are the key factors that contributed to. And so also it said, don't be discouraged by this one event. I believe this thrombosis here occurs. So what I learned is to be strict, accept outlier as an exception to the rule. The outlier is not an exception to the rule. The outlier is important and makes us understand the real rule. Otherwise, the rule is full of outliers. The outliers make the rule. A challenge the established proven or current knowledge. Heparin is not the only anticoagulant. Thrombosis depends on many other factors. These theories based on intuition and find empirical support. Sometimes the explanation comes after the success. First you are successful, then you find why. Survival critiques and demolitions, and among various, the one that I find most important is persistence. Be persistent in your ideas, not always, but most of the time, and don't give up. A cardiac surgeon was a real element in my understanding. There is no question that cyclopidine, for young doctors, cyclopidine is the old version of clopidogrel. Cyclopidine causes a malignant bleeding. I will not operate on any patient who is receiving cyclopidine, and they took this statement very seriously. Cyclopidine is a potent antiplatelet agent. There was a cardiac intervention at that time. Dr. Paul Bagan from Marseille in France. And if you start the cyclopidine a few days before PTCA, and continue, you will have left dissection which will occlude. At that time, there was no stent. Dr. Bagan used the cyclopidine as a protection against vessel occlusion. And the third person is Jonathan Tobis. Jonathan Tobis is an interventionist, but mainly interested in echocardiography and in intravascular ultrasound. And he taught us to use IVUS and to see that after stent implantation, despite a good angiographic result, you see incomplete stent expansion, and after high pressure inflation, the stent expands much better. These observations cannot be obtained by angiography. You need something looking from inside. And all of these made us do this work. To me, this is the most important paper I ever published, and I could stop publishing paper after this one. Everything else is redundant. But in 1995, we published about intracoronary stenting without anticoagulation accomplished with intravascular ultrasound. And we use the peclopidin, aspirin, and ibuprofen. We reported about 359 patients with only 0.9 thrombosis, which was a very important achievement. So this last slide concludes the history. And the history is also based on what medical students know about the Virchow trial, the prevention of thrombosis. And I always tell that it's like a chair, like a stool. You need three elements to prevent thrombosis. You need a good lumen, you need a good runoff, and you need appropriate treatment of the blood, antiplatelet agents. And you can make these legs of titanium, but if you do not have the other legs, this chair, this stool will fall. So you have to count on three elements, and all three elements needed to be in the right proportion. You cannot believe that if you place a stent badly, by giving a strong antiplatelet, you will be able to correct. The three elements needs to be in the right proportion, otherwise the stent will fail. So let's go now into the future. You all know about stenting, 40 years of stenting, randomized trial, etc. What stenting has done has consolidated the immediate results after the procedure. But there are two prices that you pay when you implant a stent. You do not benefit from positive remodeling, and positive remodeling is the growth of the vessel if you form atherosclerosis inside the vessel. There are many arteries that have atherosclerosis, but they are not narrowed because you have positive remodeling. Positive remodeling is a natural compensation to disease formation. And with stenting, you also take away pulsatile strength. Diastolic systolic excursion is a way to transmit the blood flow to the distal bed. So with these two, you are taken away. And this is a practical example. This is a disease of the circumflex with a lot of disease. Was treated with implantation of 3 bioresorbable stents, at that time Abbott scaffolds. And these are the immediate results. But 3 years after, what is unique that without a metal, you can increase the lumen. The lumen went, you can see even visually the lumen here to here. The mean lumen area went from 4.9 after stenting to 7.3 3 years after. This is impossible to be obtained with the metal stent. Of course, you can obtain this also with the drug-coated balloon, but you need something that disappears to allow a positive remodeling. So, nothing wrong with stents. Stents save life. Stents are implanted to prevent occlusion when there is a dissection or to overcome recoil post-balloon dilatation. Stent should not be used to treat atherosclerosis. Atherosclerosis is a much more complex area that should not be treated just by stenting. We hear frequently the lesion needs to be covered by the stent. I like to change it into the bed dissection or the lesion with recoil needs to be covered by the stent. The idea to place the stent from healthy vessel to healthy vessel was a good idea at the time of short stent implantation, but to implant very long stent and make the vessel what we call a full metal jacket is not a very sound idea. About IBUS guidance, we discussed about the value of IBUS, guided stent optimization, and there are plenty of data showing a lower mortality in patients achieving stent optimization. Stent optimization, nevertheless, has some prices to be paid. Procedural complication, if you dilate the stent inappropriately or too much, you may have a vessel rupture. You have embolization of distal material, you have a cost, and the long-term result of some stent is still problematic. So all we did is very important, but may not be the real final answer. And if you can achieve the same result without paying these prices, why not? So all of these rights are not to detriment stenting, but to understand some of the limitations and some way we should work to overcome these limitations. Again, why most operators stent every lesion? Among the reasons, the most important is to prevent sudden closure when the result is not stent-like. And this is a very important statement. You do not want to pay the price of stent closure or vessel closure, because that's the cause of myocardial impact. And this is what I try to introduce again. I'd like to reintroduce the concept of measuring PDPA. PDPA is the pressure proximal to the stent versus the pressure distal to the stent, or to say more correctly, the pressure proximal to the dilated lesion and distal to the dilated lesion, even before having placed the stent. And if the pressure proximal and the pressure distal are very similar, let's say less than 10 millimeter of mercury difference, it means that whatever there is in the lesion is not causing an obstruction, because the flow maintains the pressure. And this is, again, nothing new. We always stand on the shoulder of other people. In 1985, I just finished my postgraduate school. Dr. Grunzig, Andrea, the senior author, published this paper, Influence of Intimal Dissection on Restenosis. And you see, here is the restenosis rate with no intimal dissection. They didn't have stents at that time. The restenosis rate was 30%. So 3 arteries out of 10 had the restenosis. If you had the dissection, the restenosis went down from 30% to 24%. So pretty positive. We hate the dissection, but at that time, dissection was a positive attribute. What is even more remarkable is the final gradient was less than 15. The final gradient is a PDPA less than 15. The restenosis rate went from 39 to 35, some advantage. But what is remarkable was what you see here. If you had the two things, the dissection and the low gradient, the restenosis rate was 19%. It's really important. So in order to have good lesion dilatation, you need what I call a benign dissection. You need a dissection, but you need a low pressure gradient, which proves that the dissection is not a bad dissection. And so we moved this forward, and in the past 3 or 4 years, we now say that the goal of modern PCI is not to implant a stent in every lesion. The goal is not to avoid stenting. The goal is to implant a stent when needed and not to implant a stent giving a drug-coated balloon, which is a way to deliver a drug to the vessel wall without a stent when needed. This was really nothing new. In 2013, we published this paper with 45% diabetics, where we wrote about the role of drug-eluting balloon alone or in combination with drug-eluting stent. It's exactly what we are doing today. And we did not do a randomized study. It was just a pilot study comparing the strategy of drug-eluting balloon plus drug-eluting stent versus drug-eluting stent alone. And at the follow-up, the MACE rate was 13 with a combined strategy versus 23. And the target lesion revascularization went from 10.8 with the death alone versus 5.4 with the combination. So this really made us become more courageous, and we start to accepting dissections without a stent. If the right coronary artery treated with rotational atherectomy and balloon, there is a linear dissection, but the residual lumen is very large. I call this optimal result, where you don't even need to do a PTPA or do IVUS. The result is so good that you can leave it alone and use drug-coated balloon. This is a bad dissection. You see there is a dissection here, but the residual lumen is small. We have a similar case today in the cath lab. In this situation, you don't need to do PTPA. You just implant a stent. Of course, stents are life-saving. But then you have so-called the group 3 intermediate result with good lumen, but the dissection gives some uncertainty. And that is where we introduce the concept of PTPA. PTPA less than 10. In case of diffuse disease, we can use it to conduct the old procedure. Some examples. This is a bifurcation lesion of the left anterior descending, which is treated with balloon. You see that there are 2 linear dissections. The residual lumen is fine, but being the left anterior descending, we measure PTPA. And PTPA was 1 in the LAD, which means that there is no gradient. Basically, pressure on above is the same as pressure below. In the diagonal was only 0.9, 9 millimeter of mercury is the difference, 0.91, and these are gave us the strength not to do anything. And all of these gives us the opening of, we are not completely ready now, but maybe in few years we can really go to metal-free PCI. We do not have many bioresorbable scaffolds. As a matter of fact, you in India make the only available bioresorbable stent made by Merrill Corporation, who makes these new generation bioresorbable scaffolds. And here is an example of doing angioplasty without metal, still utilizing stent, but no metal. This is the left anterior descending with a lesion proximally here and a diffuse disease distally. You can implant a stent if you have a bioresorbable stent. If you do not have a metal stent, and do the rest of the procedure with angioplasty. We go just quickly here because this is really nothing so exciting, and it's all technical, vision pre-dilatation, with high pressure balloon. So the idea here is to implant the barber stent proximally and the rest of the vessel with the drug balloon. So this is the future. We are not totally ready for this approach, but this is an example. There is a dissection, we measure pressure gradient, we implant the stent, and we go quickly here. We check here with the DBS, 25, 48 millimeter long, and then we go with the drug coated balloon more distant. This is the new concept of bioresorbable scaffold, dilating, etc. Let me go quickly here because and we do the circumflex with the drug coated balloon, no stent at all in this procedure. So one bioresorbable stent proximally and drug coated balloon on the distal circumflex with a metal-free PCR. We need the data, we need the studies, but the future, I believe, is to slowly move away from a metal procedure. These are some other examples. This is the circumflex, the diffuse disease, treated only with the drug coated balloon, no stent, and this is 1 year follow-up with very nice residual movement. This that you already saw in this case is the bifurcation of the LADST. This even a more extreme case is the left main with the quadriplication. We plan to place the stent on the left main toward the LAD, but the result after pre-dilatation was so good that we only did the drug coated. So this I call work in progress. This is a new idea that will need data to prove that what we say is right. We have some preliminary data. What I just showed is not only anecdotal cases. We published a few months ago this early experience of 104 lesions who underwent lesion pre-dilatation, and in 83 lesions, the result was very good, and we did the drug coated balloon. We measured PDPA because we're all long diffuse disease, and the PDPA was less than 90, and we used the drug coated balloon with a good result in 79. In 4 of them, we decided to implant a stent because we were not sufficiently happy. But about 80% we were able to do with drug coated balloon. In 20 lesions, the PDPA was not acceptable, was less than 90. We did some additional dilatation. In 14 of them, we had a good result, but we had to implant an additional stent in some part of the lesion. So we used what we call hybrid strategy. While in 6, we had to implant a full stent. So basically, 80% of the time, you may be able not to implant a stent, and in 20%, you may have to implant a long stent or a stent. These are preliminary data. We will be more confident when instead of 104, we have 1,004. But many people are working in this direction, and hopefully in the next 2 or 3 years, we will have more data. The clinical outcome was good in this patient. We have now followed up over 1 year with no thrombosis, with some restenosis, only 5. So positive result. So to finish, I call these preliminary conclusions, because these is early data, and every early data needs a confirmation by multi-center trial by many other people. But drug-coated balloon are effective to treat instilled stenosis, and this is acceptable. Drug-coated balloon can be used to treat small vessels, disease with some advantages, and this is accepted. We have randomized trial published from Europe with up to 3 years follow-up. But the new is that utilizing an appropriate strategy, drug-coated balloon can be applied to treat long lesions, limiting stage length even in large vessels. And if you have a combined strategy of a drug-coated balloon and a bioresorber for scaffold, I believe we can even move in the generation of metal PCI. So stent thrombosis at all of these causes, stent stenosis is low. Nevertheless, PCI trial demonstrate inferior results compared to bypass surgery. Better lesion preparation and better stenting may help, but I have concern about the long-term outcome of long stent, and that's the reason why we promote some new idea, and we are totally confident the stent do not prevent the disease progression, and we need to explore alternative to stenting, not to leave behind medical therapy, which is the cornerstone to long-term success. Thank you for your attention. If you have questions, I know in lectures usually there are no questions, but don't dislike to be informal, and if you have any questions, please feel free. Maybe you have to come closer.
Sir, what is your practice? How long you inflate this drug in your balloon?
How long?
You inflate, keep it
Oh,
inflated.
keep it inflated.
Because there is not
Minimum 5 seconds. But if the patient is stable, I keep it even 2 minutes.
but when you inflate the balloons and the BP falls, what do you do?
I deflate the balloon, let the blood pressure come up again, and then inflate it again.
So do you use in inotrope for bringing up the blood pressure?
I use it, but I do what I just told you. I inflate it 20 seconds, if the blood pressure goes down, I deflate it, and I inflate it again.
Right.
But usually it's not so common. Only if you do very proximal left anterior descending or left main, or you have a patient in very critical conditions.
Do you think the drug matters paclitaxel versus sinodular?
Yes, I think that's a very important question. About drug-coated balloons, we still have to learn a lot. Drug-coated balloons are not a class yet. There are some good drug-coated balloons, some mediocre drug-coated balloons, and some bad drug-coated balloons. I think we have data about paclitaxel. Paclitaxel is very effective because it is attached, it's a lipophilic, and stays on the wall. And it's less dependent on the carrier. You need a carrier, but less dependent. Sirolimus is hydrophilic, and you need a special way to package the drug to make it stay in the wall. So we need more data to absolutely accept that sirolimus is the same as paclitaxel, maybe even better, and we need the data to show that Hieronymus of the balloon type A is the same as the Hieronymus of the balloon type B. There is a lot of work before accepting this statement as generically true. At the present time, my conclusion is that the data on paclitaxel are solid, the data on sirolimus are being built.
How confidently we can leave a lesion which is when it can have the section?
I think in general, it's better not to be confident.
Thank you.
You build confidence with time, with iris, with pressure gradient, but if you have any doubt, it's better to make a mistake by implanting a stent than making a mistake not implanting a stent and have the patient have a myocardial infarction.
Regarding the regulatory balloon, primary PK, where do you think that stand today? Primary.
There is I personally do not have experience, but there is data in the literature with good results of drug-coated balloon with primary PCI. So I think, my personal opinion, if you have a good result, maybe if you have removed the thrombus and the good result is very stable and acceptable, you can do drug-coated balloon. There are papers in the literature, and this is the field. It's really, I think, again, I don't want to take anything away from stents. Stents save life, and stents make our practice survive. But like everything, you have the courage to move forward and to say goodbye to your friends, even if he was the best friend. Thank you.
Thank you so much, sir. We call upon Professor Dr. Ranjit Karthikeyan, Head Department of Cardiac Anesthesia, to give vote of thanks.
Honorable of the dais and on the dais. It is good afternoon to one and all. It is indeed an honor to be standing here today on this prestigious occasion for two chief reasons. One, the endowment oration is greatly honored by the presence of the personality associated with this oration today, Professor Thanikachalam, a teacher par excellence and a man of great human nature. Like they say, the influence of a great teacher can never be erased. A teacher's influence in all our life is an open fact. Her presence here, although you have just now, is the honor to the oration itself, not to the other. Thank you, sir, for presenting here today. Two, the presence among us, the Honorable Professor Antonio Colombo, all the way from Milan, Italy. He is one of the renowned and highly respected interventional cardiologists. It is said that a good physician treats the disease, the great physician treats the patient with the disease, and your greatness is known all over the world, sir. Thank you for accepting this oration. No doubt, your talk has been enlightening to all of us present here today. I consider this nothing less than a divine opportunity provided to me by Almighty to be able to talk to you on this honorable occasion in the presence of such lofty dignitaries all around. But at the outset, I must offer a profound thanks to the management of Shreya for the unconditional support to us in everything which has resulted in gathering here on this special occasion. A man's true wealth is the good deed he does in this world. On behalf of all of us, I offer my humble thanks to the Honorable Chancellor of Priya Sri V.R. Venkatachandram and Pro-Chancellor Sri Sindhu Tugan for the world of good deed they do and influence through seer and honoring us today. No matter how busy a person is, if they really care, they always find time for you. In this, I thank Professor Uma Shekhar, Vice Chancellor here, for her honorable presence here in support of this historic event, despite her multiple responsibilities and institutions. Thank you, ma'am. I also like to thank Professor Jason Murthy sir and my teacher Mahesh Pakamudi sir and Professor Balaji Singh, Dean of Medical College. In spite of the busy schedule, they came here. But the man who deserves a special accolade is, I'm sure all of you could agree when I mentioned Professor T.R. Muralidharan. Yes, spearhead that part of cardiology next level. The only way to do a great work is know what you do. And Professor Muralidharan stands a classic example for that. I thank Professor Muralidharan for his inspirational presence here and for delivering the welcome address. Thank you, sir. The visibility of a program like this requires the invisible presence of a lot of support staff. They are like anesthesiologists, always behind the screen, they cannot be recognized. But a special thank to the audio video support, all the Catholic team and others. I thank the Concept International and Ms. Monisha, the medical conference for this program. Finally, I offer my thanks to all my colleagues and my seniors for your presence on this memorable occasion. If I sang the praise for all your hard work and support, I could lose my loud voice pretty quickly. So I stopped short with it. And thank you from bottom of my heart for your support and audience for this historical third Thanikachalam sir Endowment Oration in Cardiac Science. This concludes the event today. Once again, thank you all for your time and presence. Jai Hind. Join us. Thank you. Thank you.